and today I'm gonna present my disease poster project on gastroschisis. So we're gonna start with the introduction and we'll go from there. So gastroschisis is a paraumbilical abdominal wall defect associated with the protrusion of bowel through the defect. So the defect isn't the fact that the intestines or other organs are outside of the baby's belly. It's a hole that developed that allowed either developed it around or allowed it to come out. So this hole is usually about 4 centimeters in size and it's to the right of the umbilicus. So that's just a little few details. So complexity is based on the absence or presence of intestinal atresia, which is when a section of the intestine is completely closed or missing, so food cannot pass through there. And then stenosis. So intestinal stenosis is when the intestine is narrower than normal, making it hard for things to move through. Then bowel perforation, which is when a hole forms in the intestine, allowing contents to leak into the abdomen. And then bowel necrosis, which is when part of the intestine dies due to lack of blood flow. Then malrotation, which is when the intestines don't form in the correct position during development. And then volvulus, which is when the intestine twists around itself, cutting off blood flow or causing a blockage. So with this defect, spontaneous delivery can occur between 37 to 38 weeks gestation. Um, it occurs in 1 in 4,000 live births, which isn't too much. It's kind of a rare thing, but it is becoming more common. And then the incidence of gastroschisis are the same between male and female, so that doesn't cause anything. But there is a higher incidence of Hispanic singleton pregnancies and younger women less than 20 years of age. And then the overall survival rate is greater than 90. So the overall survival rate means low mortality rate. So it's really good because even though this disease is scary, especially for parents, they have a good chances and good odds. So now we'll move on to the pathophysiology and the diagnosis. So in the presence of gastroschisis, AFP, which is serum alpha fetoprotein, is elevated in the mother's blood or whatever they're testing. So once I noticed that, they like kind of put on some signals like, okay, that's a little weird. But diagnosis is often made on the 20-week ultrasound with free-floating bowel loops in the uterine cavity. So that's usually when they like see it and they're like, okay, we need to keep an eye on this. This is what this is. And then once it is diagnosed with that ultrasound, fetal growth and amniotic fluid volume are charted with an ultrasound at 3 to 4 week intervals starting at 24-week gestation. And then we're going to move on to things that it can cause. So in matted bowel, there are potential bowel atresias or in utero ruptures. So the atresia is, like I said before, where the intestine didn't form correctly and is blocked or missing. And the in utero rupture is when a tear or a hole in the intestine happens before birth. Additional contents can herniate through the defect, like the stomach, the liver, the bladder, which these cases become more extreme because those are more, I wouldn't say vital organs, but parts of your bowel can be taken out, whereas parts of other organs can't be. I know your liver can be, but certain things, it just makes it more extreme whenever you have more larger, important organs coming out than just your bowel. And then bowel exposed to amniotic fluid may become thickened or dilated. This there's nothing really they can do because the bowel is going to be exposed throughout the pregnancy. But late diagnosed gastroschisis has fewer changes from the amniotic fluid. So it's less exposed and it's could be defined as better, but whenever it is diagnosed late, there can be bowel loss if the bowel herniated through the small compromise in the intestines. So if it was attempting to close as it herniated through, it can cause kind of like a clamp. It can cut it off, and that can be bad too. So with it being diagnosed or happening later, there are positives and negatives to that. But either way, the amniotic fluid does cause issues. And then infants with gastroschisis may have intrauterine growth restriction. They just struggle to grow um, than regular, not regular, but babies without this defect. And then pregnancy may become complicated by fetal demise and spontaneous preterm birth. So, like I said, spontaneous birth happens 37, 38 weeks. They want to keep a close eye because some doctors, based on your specific pregnancy, will say you can either deliver vaginally or cesarean section. So, it really just depends if you're in a complex case or if you are in a basic case. And with the fetal demise, that's when the baby passes after 20 weeks of pregnancy, which makes it a little bit harder for things to move on. Um, there are several implicated causative factors. They don't know a for certain cause of this disease, but they have a general idea of tobacco, environmental exposures, aspirin, ibuprofen, and decongestants. So those can be, and the mothers of young age can also be one. But that's pretty much for diagnosis, things that it can cause, and what causes it. So we're going to move on to treatment. Um, for treatment, there really is no treatment. There's no thing that they can specifically do to stop this from happening. No, like, vaccines or anything. But they try to do everything they can, which is why they have a 90% survival rate, which is really good. So what they do instead of trying to prevent or treat, they start with neonate management. So after delivery, the infant is protected by covering its exposed bowel by placing the lower half into a bowel bag. So this is what the bowel bag looks like. As you can see, this baby has been put into the bowel bag. You can see his intestines right here. And we're going to come back up here. So the bowel bag has warm, normal saline to protect the bowel and minimize the fluid loss because these babies are losing a lot of fluid through this bowel. And this also allows visualization of the bowel and blood flow, which is really good because, like I said, it can act as a clamp and cut the blood flow off. So next, an orogastric tube is inserted to decompress the stomach, and placement of a peripheral intravenous access is performed. So this is to provide antibiotics and maintenance fluid. They need a lot of fluids, 2 to 3-fold, due to all of the fluid that they're losing through this bowel. And then now to the treatment. So two treatment options are presented for gastroschisis. And the primary goal of these treatments are to repair and return the exposed bowel and other organs back to the abdominal cavity while minimizing the injury. So with these two options, there's primary repair and there's delayed closure. So with delayed closure, they use a temporary silo and performing serial reduction of bowel contents. So they delay the primary closure following the silo reduction. So I'll show you what a silo looks like. This is a silo. It's basically a bag that they kind of keep it upright. And they're using this to kind of see if gravity will help them move the intestines back down. That way the baby's not going through 2 surgeries. And then the other primary repair option is performed just straight operation, or it's after the successful bowel reduction back into the abdominal cavity is performed. So one or the other, it really just depends on the baby situation. But either way, with both types, the primary and the second delayed closure, there have been no differences between length of stay, feeding, or ventilator times. So that has been kind of good. We'll move on to the global impact. So for global impact, rates of gastroschisis are increasing worldwide, which is kind of a scary thing, but we are maintaining that 90% survival rate, so that is good. And then worldwide rates of gastroschisis in industrial nations vary between 1 in 2,000 and 1 in 33,336. Although some regions have higher rates, such as Wales, which is reported at 1 in 16,127 births, and an area in Australia, which is as high as 1 in 8,928 births. So it really just varies on country because there are a lot of differences, which is kind of strange, but and in a 2009 report from 16 separate registries shows that South America as a whole has the highest reported incidences of gastroschisis in the world at 1 in 1,063 births. That was that's kind of really low compared to the average, which is 1 in 4,000. And then a baby with gastroschisis may continue to have problems throughout their life. So this affects their life throughout it. And they might have problems eating, digesting, absorbing nutrients, and moving food and waste through the intestines. And they might still continue to have growth issues even outside of the womb. So we'll move on to social response now. So there is a global gastroschisis foundation known as Avery's Angels that provides support, education, advocacy, community programs, and all of this is for patients and families affected. You can also volunteer and donate to this foundation, but it also promotes awareness, funds research initiatives, and connects families worldwide. This helps improve outcomes and understanding of the disease. But it also just shows like there is a big societal impact if this is a global organization. And still, there are no vaccines or drug therapies available to treat it in the womb or prevent it. And there aren't really any controversies socially, but there are between doctors. So some doctors may argue that one treatment option is better than the other, considering there are two. Some doctors may argue cesarean is better than vaginally birth. It just depends on the doctor, but some have strong beliefs in the way that this disease should be maintained. So now that is pretty much everything. I'm gonna go to this diagram and just give you a closer look. This is inverted, otherwise it would be, for you guys it may be, no it won't. It is inverted, so this should be to the right, but it's not on the screen. But this would be about 4 centimeters in size. And this is all just coming out. And this is the umbilicus, so it is to the right. And it just floats in there with the baby in the amniotic fluid. And so this is what it would look like. This picture's a little bit graphic, but this is kind of what it looks like. I don't know why they don't have this baby in a bowel bag, but they probably have their reasons. And so I have my references down here, and then we'll come over here and talk about the conclusion. So, early diagnosis and careful prenatal monitoring greatly improve the outcomes. I do believe this is why there are such good outcomes. And prompt neonatal stabilization and appropriate surgical repair are key to preventing the serious bowel complications. Because, like, all these steps that they do when the baby comes out really do contribute to what the baby's about to go through, which is surgery and just getting it good and healthy. And then, even with high survival rates, ongoing follow-up is important due to possible long-term feeding and growth issues.